Good afternoon, everyone. Today it's my pleasure to introduce Dr. Marco Vaz. Dr. Marco Vaz started his training in Brazil back in 1983 in the School of Physical Education, Physical Therapy, and Dance. After his undergraduate degree, he completed his PhD here at the University of Calgary with Dr. Walter Herzog, which he finished in 1996. While he was at Calgary, he studied the mechanisms of muscle vibrations during stimulated and voluntary isometric contractions in both human and animals. Dr. Vaz is now a professor back at the same university where he completed his undergraduate degree, and in the past decade has become the director of the Neuromuscular Plasticity Lab at his university, became president of the Brazilian Society of Biomechanics, a member of the Executive Council of the International Society of Biomechanics, and a member of the World Congress of Biomechanics. Currently, Dr. Marco Vaz has a number of interests that stem from his research using neuromuscular stimulation, including training human skeletal muscles, treatment of osteoarthritis, and treatment of people who are critically ill. He also has interests in neuromuscular adaptations with respect to recovery from Achilles tendon rupture, patellofemoral pain, and femoral acetabular impingement. In the future, Dr. Vaz intends to extend his work on neuromuscular stimulation and understand the changes in muscle due to bed rest and how these can be counteracted by a progressive protocol involving neuromuscular stimulation. So outside of academia, Dr. Vaz is passionate about hiking, and maybe secretly that's what's motivated him to come back to Calgary to do his sabbatical. He has hiked the West Coast Trail and several other trails in the Canadian Rockies. Dr. Vaz also believes that all of this hiking has helped him develop and understand that in life it is important to enjoy the journey and take everything one step at a time. Although Dr. Vaz really enjoys hiking, the most important thing in his life has been all the incredible people, scientists, and students he has met and all the things that he's learned from them. So today, Dr. Marco Vaz will present on electrical stimulation for neuromuscular testing and training.
Thank you, Mike, for the introduction. You guys can hear me in the back? Okay. All right, before I start, for those who do not know where Porto Alegre is, so this is Brazil. If you go to the south of Brazil, the last state is Rio Grande do Sul, and Porto Alegre is right here. So it's about 1 hour, 1 hour and a half from the ocean, the Atlantic Ocean. Has a population of 1.5 million people. It's a large city. It's a more vertical than horizontal city as Calgary is. Has 2 soccer teams that were world champions. So people are passionate about soccer in Brazil. And the Brazilian cowboys, also called as gauchos, they like to drink, tea. They like to dress, in a different way. That's the way the gauchos at the Pampas, they dress. They like to sing, and they like as well to watch the sunset at the lake in our city. First time I brought this tea here when I was a student, Beno looked at me as if I was bringing drugs to the seminar, and I had to explain, no, that's just regular herbal tea. So that was my first experience here in the lab in the first seminar. So what I'm going to talk to today, I divided into 4 steps or 4 parts. So we're going to talk about neuromuscular electrical stimulation, or just NEMS, its applications, the parameters that we need to use, which are the limitations of this technique, which are some of the solutions for these limitations, and then I'm going to show a couple of studies that, one that is undergoing and one that we have finished on assistive technology using NEMS. So on the applications, so what we use neuromuscular electrical stimulation for, we can use it, for the evaluation of the neuromuscular system. We can also use it to improve muscle function, to preserve muscle function, and to restore muscle function. So let's try to look at each one of these situations. So for evaluation, usually what we have is that, we have electrodes over the muscles, and we have a dynamometer, and then basically we try to see what's going on with the muscle, how healthy is this muscle, how much force it can produce. And then we can do this with healthy subjects, and we can do this as well with patients. For strength training, we can use electrical stimulation basically, to increase the amount of force and increase muscle mass of, of our muscles as an additional tool to, basically the load or the force that you are acting your muscles against. To preserve muscle function, it has been used for several things. For subjects that had stroke, for elderly subjects, it has been used for both microgravity and space flights. They have been used as well to spinal cord injury and to the intensive care unit. So in these cases, we want to preserve muscle function. To restore muscle function, it has been used in orthopedics for ACL rupture, osteoarthritis, total hip replacement, as well as cardiovascular and respiratory problems. And so there's a large usage of this technique to restore muscle function. So is it effective to restore muscle function? Well, if we look at, for example, voluntary exercises and NEMIS in healthy subjects, according to Bax and co-workers, well, no, of course, voluntary exercise are much better than electrical stimulation, to produce increasing muscle force and muscle mass. However, if you look at the patients, most patients cannot do voluntary exercise, and then basically, studies have shown that NEMIS is better than voluntary exercise to produce adaptations. But how do we use this technique? Which are the most important parameters that we have to control? Well, first let's define what is NEMIS. NEMIS is the application of a series of intermittent stimuli to the innervated muscle in static conditions with high current intensities, and the idea is that I can trigger a visible muscle contraction. So that's basically how it is defined. And to do that, to achieve these goals, basically we use several parameters that are important when we use electrostimulation. The on-off ratio means the amount of time that I have the contraction being on by the stimulation, and the amount of time that I have of rest between these contractions. We also use ramp up and ramp down. So basically the stimulus, it increases slowly so that it's not very uncomfortable. So we have a ramp up and a ramp down. And then this is, for example, here we have 5 seconds of total muscle contraction. The shape can vary in different types of stimulators. You can use a rectangular biphasic shape, which is shown here, but we have also sinusoidal shapes. We have triangular shapes, so there are different shapes that you can use with this technique. The most used one is the rectangular though. For the post duration is the amount of time that the stimulus is on. Basically, it varies from different studies from 100 to 500 microseconds. The frequency that has been used in most studies range from 30 hertz to 100 hertz. And in theory, the intensity that you want to use is the highest one that people feel comfortable with. So the highest that you can go. There are different types of currents that you can use to stimulate the muscle. The two most common ones are called low frequency pulse current, which is this one here that you see, and the kilohertz frequency alternated current, so which is this one here. And we'll talk a little bit about each one of them. So what is the low frequency pulse current? It is defined as having successive phases or pulses that are separated from each other by a significant gap or an interpulse interval. The pulse waveforms, as I mentioned, can be rectangular, sinusoidal, or asymmetric, and they can have one positive. When they have just one positive phase, they're called monophasic, and when they have a positive followed by a negative phase, it's called a biphasic current. What about the alternated current? It's by definition, it is biphasic, so there's no monophasic alternated current. It is a sinusoidal shape. It can have also triangular and rectangular shapes. It is delivered to the muscle. If I would deliver this continuously, then I would have a lot of high frequency fatigue. So basically when we deliver the alternated current, we modulate it in bursts. So here, for example, we have 2 bursts. It is defined as a medium frequency stimulation, and it goes between the range between 1 kilohertz to 10 kilohertz. The most common used one is 2.5 kilohertz. And then you modulate these bursts between 1 and 120 hertz. This current is interesting because it was proposed in the 70s, and it was by the pioneer works by Kotz and Svilian and Kotz. These are two Russian scientists, and when they proposed this new modality of current, they said that would solve some of the limitations of the traditional neuromuscular stimulation. They claimed that this current here, that was later named as Russian current because of them, would increase the maximum voluntary isometric contraction up to by 40%. So I would have 140% of force if I use this kind of stimulation. Why would that occur? What was their rationale for that? Well, they said that by using suprathreshold intensities, with bursts that were long enough, then you would be able to generate multiple nerve fiber action potentials per burst. So each one of these bursts would generate several action potentials at the motor nerve, which would then produce a smaller discomfort. You would have more current going through the skin, so this would be less discomfortable. And then it would elicit greater force than the traditional NEMES. However, the problem would be, basically, as I mentioned, the rate of fatigue, that you having more action potentials, you'd have more fatigue. Well, it has been widely used in physical therapy. Electrical stimulators have been widely sold. In Brazil, almost every single physical therapist has used in their professional life the alternated current or the Russian current. And that's interesting because it's fairly well used, despite the small number of evidence in support of the original claims made by these scientists. So because of that, then we decided to try to understand a little bit what happens when we use these two current types, we call the Russian current and the pulsed current. And we looked at two different outcomes, the discomfort level and the current amplitude, to produce 10% of the maximum knee extensor torque. We use 10% because most of our voluntary contractions are usually done at 10% of the max. So it was kind of a physiological way of trying to understand the effect of these two currents and having a constant torque output for the two current types. So these are the main results. So here, if we look at current amplitude, and here you have the pulsed against the Russian current, you can see that to produce 10% of the maximum voluntary isometric contraction, you need more current amplitude at the Russian current compared to the low frequency. So that means that Russian current, in our case, was less efficient than the pulsed current to produce 10% MVC. When you look at the discomfort levels, again, you have lower discomfort levels using pulsed current as opposed to the Russian current. But then we tried to understand a little bit better, because our study was a very simple one. Then we tried to understand what other scientists had done in terms of comparing these two current types. And then we just published, a scoping literature review this year, looking at basically the comparisons of these two current types and trying to look at more outcomes than we did in our original study. So the first thing that was interesting to find is that these 14 studies, they had a low to moderate methodological quality. So they were not very good. Some of them were good, but none of them was excellent in terms of the methodology that they used. For the evoked force, which is the main thing that we want to understand, it's the output from the current. Well, studies varied from 20 to 77%. So there's a kind of a wide range of results using these two current types. But it's important that none of the studies achieved 140% of the maximum voluntary isometric contraction as originally claimed by the Russian scientists. We also looked at discomfort level. We looked at current intensity to produce maximal current intensity, produce evoked torque, neuromuscular efficiency, and fatigue. And then, the basic conclusions that we arrived at is that the alternated current is not better than the posted current because it generates equal or less force than the posted current, equal or more fatigue than the posted current, and equal or more discomfort than the posted current. However, it's important to understand that we have limited evidence, and the low to moderate quality of the studies calls for better, well-designed studies so that we can reach a final conclusion. Well, what about NEMS activation? How does the activation of the neuromuscular system occurs? Is it similar to the activation of a voluntary contraction? So it's important that we understand what exactly we're doing when we're stimulating, the neuromuscular system. And the answer for that question is no, they're quite different. If I look at voluntary contraction, the recruitment order of motor units is orderly selective. So I go from small motor units, slow contracting, to faster and large motor units, according to the size principle proposed by and shown by Henneman in 1975. NEMS is different. It is disorderly and it's non-selective, as we'll see. The other thing is that voluntary contractions, they are asynchronous and they are dispersed. There's a rotation of motor units during voluntary contractions, and it's quasi-complete. I can almost activate all motor units. With NEMS, it is synchronous. I activate everyone at the same time. It's fixed and superficial, and it's quite incomplete. So if I would look here at the motor units in these two situations, so that's basically what would happen. So you see that I'm activating a certain group, then I activate another group, so there's this rotation of motor units during contraction. For the NEMS situation, I'm usually just stimulating the same number and the same specific motor axons. Does NEMS use the same nervous path that the central nervous system uses for muscle activation? So to use the same connections? Well, basically, NEMS has both peripheral and central effects. You're stimulating basically, your current is going at the skin level, and then you have both an efferent propagation when you reach the motor nerve. So you have an efferent propagation that goes into the contractile proteins, making the muscle to contract. But at the same time, you have the stimulation will go upwards. So you have an afferent propagation. And then you have also information coming from skin and subcutaneous receptors, and all these afferent information are going to the central nervous system. So basically what happens is that, well, you activate different types of nerve fibers, and then you have both at the spinal cord and at the brain, you do have information that is going up and down when you're using NEMS. One way of showing this important central contribution to muscle contraction is that when we just change the parameters of electrical stimulation. So here I have the force produced by two different contractions. The first one, I'm using a current with 25 hertz and with basically a pulse duration of 50 microseconds. And then to produce the maximum intensity that this subject was able to sustain, I needed to input 110 milliamperes of current intensity, and I was able to produce a maximum torque of 70% of the max. When I just changed, from 50 to 1,000 microseconds or 1 millisecond, and I increased the frequency from 25 to 100 hertz, I needed about 25% of the same intensity, and I produced 45% of the maximum automatic contraction. So this is attributed to central contribution, and it's now called wide pulse NEMS because of the wide duration of the pulse. What are the limitations and solutions that we have for this technique? Well, one of the most important limitations is the excessive discomfort. It's not pleasant to have electrical stimulation on your skin. The second limitation is that you have limited spatial motor unit recruitment, as I shown. So you recruit the ones that are closer to the electrode site. And you have high muscle fatigability, and you want to diminish the amount of fatigue, because all these factors, they determine how much force you're going to produce, and the amount of force that you're producing will determine the adaptations that you have at the muscle. What are the solutions that have been proposed? So I'm going to talk about these 5 solutions. So the electrode size, electrode positioning, how we quantify the evoked force, the subject position, that is important as well, and the adequate protocol to reduce fatigue. Okay, electrodes. We want to go with large electrodes. The larger the electrodes, the better, because then I have this current is being dissipated through a larger area, and then basically this will decrease the discomfort. So that's why you try to use as large as possible electrodes. And then we try to position these electrodes at the motor points, and then basically you try to find the exact motor point in that muscle. And well, Bota and co-workers have proposed, a kind of a small little atlas or a map where you can see all, the motor points from each muscle. So this is good because then you have a kind of a guide where basically you're going to try to find the motor point. And then you want your electrode to be in the top of the motor point and not outside it, because here you're going to get more sensory nerves and you have more discomfort, whereas here you have more contraction. And so what you do is you go with the pen-shaped electrode and you try to find that spot where you have the best contraction, and then you mark that point and then you put the electrode. And so basically, if you do this, with the subject, then you have this pen-shaped electrode, and then you try to find that spot where you have the strongest contraction. That's where you're going to put your electrode. We did a small study, hasn't been published yet, but we tried to see if that is good, if going to the motor point is good. How does that compare with the femoral nerve, which is the place where previous studies have used before going to the motor point? And so we compared basically muscle inhibition, looking at femoral nerve versus motor point stimulation at the quadriceps muscle. So basically, we did find the motor point as I just showed in the previous slide. And then for the femoral nerve, we used the ultrasound, and then we looked basically where we would find the artery and vein, the femoral artery and vein. And then we knew that that's basically where the femoral nerve is. So, and that's basically where we put the electrode. So we looked at 16 healthy women, young women, and then basically we had our rationale, or our hypothesis was that the motor point, although it's easier than the femoral nerve in clinical practice, so it's much, much easier to find, with the pen electrode, the motor point, than having to use an ultrasound system to find the femoral nerve. At the same time, NEMS at the motor point would need higher current intensity, would produce higher discomfort, and mainly because you have higher subcutaneous fat thickness on the top of the motor point as opposed to the femoral nerve, and then you have higher impedance. And this would produce a smaller evoked torque than the one produced at the femoral nerve, and also due to the discomfort and to the impedance. Okay, so here are our main results. So this is resting double torque, so double stimuli, and then as a function of different joint angles. And why did we do at different joint angles? Because we wanted to check as well if there was a change by change in the quadriceps length, if this would change as well, how was the behavior of the motor point to the skin surface where we had basically our electrodes placed at. And then as you can see here, so in black you have the motor point torque, and in gray you have the femoral nerve. You can see that in almost all of them, or 3 out of 5, you have more evoked force at the femoral nerve compared to the motor point. When we look at the discomfort, you can see that, again, 3 out of 5 situations, you have more discomfort at the motor point as opposed to the femoral nerve. With respect to muscle inhibition, that was one of the main outcomes that we wanted to look. So muscle inhibition was interesting because only at 45 degrees, we had more muscle inhibition at the motor point compared to the femoral nerve. In the other ones, we couldn't see a large difference. There was no difference. And we believe that this is related with basically the position of the joint. And then at this position, you have a substantial amount of force. And then basically you have a smaller area between the patella and the femur. And so you have more stress at the cartilage, and this probably, gives you more inhibition of the muscle so that you wouldn't have more, hazardous for the cartilage at this specific joint angle. And the final result, we looked at what we call the recruitment curve. And so here you have the motor point against the femoral nerve, and that was quite interesting. Basically what you do here, you stimulate at 100 supramaximal, and then you stimulate at steps of submaximal level here so that you can construct this curve. And what was interesting here is that for the submaximal level from 10 to 50%, you can see that the evoked torque at the motor point is higher than the femoral nerve. And as you go higher from 70 to 100%, then the evoked torque is higher at the femoral nerve as opposed to the motor point. So for submaximal activation, apparently motor point is better than the femoral nerve. And it's probably due, to the discomfort here that's not so good, so large, but here you have a larger discomfort. So you may have some inhibition due to the discomfort. So the conclusion of this first study was that quadriceps motor point stimulation needed higher current intensity, produced higher discomfort, and smaller evoked torque compared to femoral nerve stimulation for evaluating quadriceps muscle inhibition in young, healthy women. And as I mentioned, basically here at the 45-degree angles, it's basically because of the patellofemoral contact area was probably the determining factor for the muscle inhibition that was only seen at the 45 degrees. Well, the conclusion is that the femoral nerve stimulation is better than the motor point because it uses smaller current levels to produce a similar evoked force of knee flexion, and so it's more efficient. Okay, so when we use NEMS, we want to quantify how much force you're producing with this stimulation. And there are different ways of doing it. I can use, for example, handheld dynamometers while I'm stimulating. I can fix the handheld dynamometer to a specific system or a table or something like that. Or I can, develop a new system basically, to measure how much force electrical stimulation is producing. And so you want to quantify this amount of force that is being produced. So you have your input is your stimulation. So basically it goes into the neuromuscular system, and then you have the output coming, which is your evoked force by NEMS. But what is important about the evoked force is that you want to compare this force with something that is common to every single person. And then basically what we do, we try to compare the evoked force, for example here 200 Newton meters, to the maximum voluntary isometric torque. And so basically I can then quantify, relative to the max voluntary contraction, how much force was produced by, by this NEMS stimulation. And it's important because the NEMS intensity is equal to the NEMS dosage that I'm using, and this is linearly related with the effectiveness of this technique. Patient position, that's something important. I was quite surprised when I started using electrostimulation in studying, because the most common patient position during the use of this technique is the one that you're seeing here. So almost every single physical therapy clinic, you'll see people laying down and electrostimulation being done as you are seeing here. And that's probably good as an initial position for post-surgical rehabilitation where people cannot move their joints. So it makes sense. But for example, it wouldn't be good for the elderly, because elderly, they have different changes and different situations than a post-surgical rehabilitation. And you need to adapt the patient's position to the patient's needs to produce the desired adaptations. What do I mean by that? For example, elderly, basically they lose serous sarcomeres, they have fascicles that are shortened, and at the same time they lose parallel sarcomeres, so they lose an anatomical section area in their muscles. So their muscles produce less force in a smaller range of motion. So what you want to do is you want to stimulate the muscles of the elderly in a lengthened position, because then you basically can increase this range of motion of the muscle fascicles. And this is related to improvement in functionality. And at the same time, you're increasing the parallel number of sarcomeres, so increasing the amount of total force. So this is the more adequate for the elderly when you want to stimulate them. And for the fatigue levels, if you want to decrease the amount of fatigue, then you need to define adequate methods. So you need protocols with an adequate length of stimulation and rest time to avoid fatigue. You want your overload, to be there, and you want some progression in this overload, because that's the way you're going to increase muscle mass and you increase muscle strength. So here, for example, we use this with the elderly, and you can see here that we increase the mechanical overload by increasing the total time of the stimulation period, and we reduce the resting time and maintaining the time of contraction constant. But then this gave us an increase in the volume of overload. Okay, so let's go now to some of the applications that we have done with NEMIS as an assistive technology. So the first study that we did was basically trying to help elderly with osteoarthritis. And then basically this is one of the studies out of this project that we basically showed that NEMIS reduces structural and functional losses of the quadriceps and improves the health status in patients with knee osteoarthritis. And then basically what we did, we developed an electrical stimulation, a portable one that was elderly friendly. Why it was elderly friendly? Well, it has 3 buttons here. A button to turn on. This is the button that you control the intensity of the stimulation, and this is you just when you start the program. And then we created a small little very simple thing, basically to restrain the movement so that I would have the isometric contraction at the lengthened position. And so it was very easy to train the patients to use the stimulator, and all the protocol basically, I have a 12-week protocol inside that, so I can basically put my protocol there, he can take it home, and then he can use for 12 weeks. And then basically I'll have all the stimulus that have been delivered to the skin of the subject. And then I can see exactly if he did what he was supposed to do or not, or if he stopped the protocol before the time. So I have an output that I can download later on from the electrical stimulator. And then basically this is one subject, for example, using the stimulator. So as you can see here, he's looking at the screen, there is no current, muscles are not contracting, and then he can adjust the intensity of the of the stimulation if the contraction is too high, as you will see in a few seconds. Okay, started, you can see the contraction, and then it's decreasing a little bit because it was perhaps a little stronger for her. Okay, what are the main results from this study? So these results here, I'll summarize in this result here. So here you have an elderly subject that does not have osteoarthritis. When you look at that muscle architecture of the vas lateralis, you can see this is the estimated fascicle length, this is the muscle thickness and the pronation angle. And this is a subject before using our electrical stimulator with osteoarthritis, and you can see that it has almost half of the fascicle length, and it has a much shorter, muscle thickness. And then 8 weeks after using the stimulator, you can see that you have an increase in muscle thickness that is close, to the value of the healthy elderly, and at the same time you have increased the fascicle length. So it was quite interesting that our assistive technology was able to improve the structure and the function in these patients. And we also had an increase in the peak torque from pre to post stimulation. So the conclusions that we have here is that 8 weeks of NEMIS improve knee extensor structure, knee extensor's function, basically torque, improved as well the WOMAC score, so functionality improved, and all the subjects said that improved their quality of life. They were able to do their daily life activities in a better way after the 8 weeks of neuromuscular stimulation. Okay, the second, and now going to the end of my talk, the second assistive technology that we developed is to use at intensive care units. And so the idea was to develop and to apply a portable neuromuscular electrical stimulator, which would be similar to the one that I just showed you, to improve neuromuscular functionality and mobility of critical ill patients at intensive care units. Well, I have currently it's under data collection, so we don't have results yet to show you on the patients. But this is the system that we developed. So we developed this multifunctional electrical stimulator. It has 2 channels. It has a pen that you just saw on the previous slide, showing how to detect the motor point. And then basically I can use these channels simultaneously or alternated. And so I can do different things. And all the parameters I use basically, the touch screen here to basically set up all the parameters in the protocol. Okay, now we need to go to the ICU and I need to measure the evoked force from these subjects. And then, well, I thought in the beginning when we started the project, okay, let's go with a handheld dynamometer. It's easy, it's portable. I can basically go to the bed and then, put there against the limb of the subject. And then, as the person is doing here, so I thought what was going to be very simple and very easy. And then when we went, basically to the ICU, it was not quite the way we expected. Why? Well, the bed is very soft. And then basically I would have to have a ladder here because, it's very high as well. So the beds are very high. So the subject will have to, go upstairs to put, the handheld dynamometer and trying to get a stable position. So didn't work. So the second assistive technology that we developed basically a dynamometer for the ICU that would be more stable. So it's very simple. And then it has basically a commercial, load cell that, you can affix to the system. And then basically that's how it looks with the patient, laying in bed. So I fix the whole system here. I fix, the leg there. And the good thing is that I put this underneath the subject and then I can reach the motor point and then it's in a lengthened position, the position that I want exactly to improve muscle function and muscle structure. So we tested the system using doublet and twitch stimulation. The large ones with 1 millisecond duration with an interval between the stimuli of 8 milliseconds. And then basically what we did, we tried to see how much force was being produced. First to test our dynamometer to see if it was working well. And then second, we wanted to see how much of this evoked force here was related with a voluntary contraction in healthy subjects that were laying in bed. So we kind of have a fake intensive care unit so that we could check, how good was our system. And then basically because patients at the intensive care units, they cannot perform voluntary contractions. So I had to rely on something else. So I had to rely basically on the evoked torque that we could produce. And so basically we were able to observe, for example, that when you use a doublet contraction, basically you produce about 20% of the maximum voluntary contraction voluntarily. And when I used a twitch, a single stimuli, then basically I produce about 10% of the maximum voluntary contraction. So now I could basically use the twitch, which is less discomfortable. I could use the twitch as my reference force to use at the ICU. So that's basically what we are doing right now. And then, but before going to the ICU, I wanted to train the team. And so we tried to do a reliability study. So we had, comparing the same subject against himself in different days, and then comparing 3 raters on the same day to see if our evoked torque would suffer, and then we had 2 analysts analyzing the data as well. So we did this both for muscle architecture and for evoked torque, but I'm going just to show things about the evoked torque. So here is the maximum voluntary contraction and you can see that the subject is making the force, and then we go to find the motor point. And so this is a top view. And then I put the electrodes basically on the motor point, and then basically this is when I have the twitch and double stimulation, and so that's basically when I can check the force. So for this study, looking at the reliability, here is for the maximum voluntary isometric force. So it was quite high, the interclass correlation coefficient. And then for the evoked force was even better. So yes, our system worked fine, both for voluntary contractions and for evoked force. When we looked at the 3 different raters, it went a little bit down, but still it's quite good. so the reliability was very good. So that gave me confidence that we could go now for the intensive care unit. So that's what we're doing right now. Well, it is a multi-center study. We're starting at this university hospital, which is the Porto Alegre Clinical Hospital. Then we are planning to go to 2 other hospitals because, well, they have different patients, and then we want to check if our protocol or our methodology is adequate for different types of patients. These patients, they have high complexity, and so it's going to be kind of walking on the moon, trying to understand what's going on with different patients and trying to see if the things that we have planned are going to work or not. This is the protocol, the 7-day protocol that we defined. So why 7 days? Because at that hospital, the average time that a patient stays at the intensive care unit is about 7 days. Although we did have planned for 21 days, we had a protocol for 21 days, we decided first to test the 7-day protocol. It is quite short, but it's important to understand that when you go to an intensive care unit, you lose between 3 and 5% of muscle mass per day at the intensive care unit. So if you stay, let's say, 10 days, you can lose between 30 and 50% of your muscle mass. And intensive care unit patients, sometimes it takes between 1 and 2 years for them to recover about these losses that they have in a short period of time. So we cannot probably avoid the muscle loss that they're going to have, but we want to basically slow down the amount of muscle mass and muscle force that they're going to have during the 7-day period. And so, and we try to do here, we try to increase, we have an increase in the volume or the load to the muscles by changing the parameters of stimulation, decrease the resting time, and then we increase the total session time. So we start at 20 minutes and go up to 23 minutes. So that's basically, what we're going to test at the hospital. And well, our assistive technology for the ICU, so the stimulator produced the desired effects that we wanted in terms of evoked force. The dynamometer was reliable and adequate for the use at the intensive care unit. Our new protocol, we hope it works, and it's based on the evoked twitch torque. It is supposed to produce a submaximal contraction of 10 to 20%, and that's important as well. Why? Because these patients, they have a general inflammatory process, and then I don't want to create more muscle damage and create a new source of inflammation, and that's why we're going very submaximal. And in this way, we'll be very safe, and we won't add other clinical problems to the patients. So we hope it will be adequate to use with the critical ill patients. For the future, that's what I'm going to do here in this year. So the idea is that, well, we developed a rabbit quadriceps femoris muscle adaptation to, in a reduced use model versus, using NEMIS with another group of rabbits, and then we're going to check the structure and functional aspects of, this model. So we're going to use the same protocol in a similar way and try to see which are, basically the more intrinsic and more direct measurements that I cannot get with patients. So the take-home message is, well, to use this technique, knowledge of the features is very important so that I can choose those that are adequate to my goals. NEMIS has several applications that are relevant, going from strength training to clinical practice in several, disease models. However, more evidence from well-designed studies and with excellent methodological quality are needed before we can increase the use of this technique in clinical practice. I'd like to finish by thanking several people, several professors, engineers, people from my research group, several students, and all these, the universities and the hospitals that I have been and that I've been working with. Also, I would like to thank the University of Calgary, the professors here, the staff, students and postdocs. I also learned so many things here, and it was so important to my life. And the unique experience that I had as a student, as a visiting professor, this is my second time here, have been fantastic. So that is very important to me. And some of you have become, very good friends over the time. So it's always good to come back to Calgary. And of course, I want to acknowledge the funding sources and CAPES that is allowing me to be here for 1 year more for this new study. Thank you.
Floor is now for questions. Yeah, I can start. You mentioned that there's like high variability or complexity in the patients that you would treat with neuromuscular stimulation in the ICU. So what are some factors that contribute to like better patient compliance to using it, or have you noticed any factors that that would either increase compliance of using it or reducing it?
Well, it depends on the clinical problem that each patient has. So, for example, if you look at, let's say, heart surgery, patients that undergo heart surgery, they stay a very short period of time at the ICU, so it wouldn't be beneficial for them because they stay between 3 and 4 days. So enter and try to stimulate them probably wouldn't have a huge impact. But they have a very long period of recovery at the hospital, and so we are probably starting a new project next year. We're going to basically not going at the ICU, but we're going to go basically when they're at their hospital beds there and the rooms, so that that's probably the most important. So my protocol wouldn't be beneficial, for example, for any kind of cardiovascular problem, as opposed to all the other situations where you'd have the subject staying for a longer period of time. For example, when we have contagious disease, then it's difficult for us to enter because there are more restrictions. So although it would be beneficial for the patients, it's a little bit more difficult for us to enter the ICU in these situations. So there are more restrictions. So, and then each type of clinical problem that a subject has might need a specific type of protocol. So, and we don't know exactly what would be the best protocol for each one. So we're starting now with whatever we can get in terms of patients. We're not trying to get a specific group of patients at the intensive care units, and then we'll try to learn from that and see which ones had benefits, and then try to see what has to be adapted for the other ones. But I can't have a good answer for your question right now.
I'm curious about your design for like OA treatment of the knee, because you basically showed that it was able to change the morphology of the person's muscle after being used, and that in the short term the person felt like a better quality of life because they had a better functionality of their joint. But what do you think the long-term consequences of that would be? Because if the person already has advanced or moderate osteoarthritis in their joint, and you allow them to use them more extensively, and it may change the stress level of that joint, and if it already has a degenerative structure, do you think it could speed up the process of degeneration over a long period of time?
I don't think so. Well, the problem is that, well, what these patients, they have is muscle weakness. Sometimes they can't even, stand from their chairs. And then the basic problem is that this muscle weakness is that increases the overload over their joints. So what we did is that by increasing, muscle structure and muscle force, they were able basically to stand up easily. They were able to walk, and they decreased the amount of load in their joints. So I think we can basically give them more time before they have to undergo, surgery. So I can't avoid that they, probably might have to go to total knee replacement, for example, over the long period of time, but I can postpone this, much longer if I actually act upon their muscles. And so I'm not trying to avoid osteoarthritis. I'm trying to enter in the vicious cycle where you have more muscle weakness, you have, less muscle force, and then you have more load on the joints and you have more degeneration. So I can't basically, I would need something different to work at whatever is already degenerated in the cartilage, but that wouldn't be, used with a neuromuscular stimulation. But perhaps in the future, they're just saw on TV the other day that they're trying to, to change and create artificial cartilage that perhaps in 10 or 20 years, I think the editor of the Journal of Biomechanics has a project on that where he's trying to create this kind of new cartilage that you could put on the bone, and then you would put chondrocytes there, and then you could have a new cartilage being replaced there. So that's something that might happen in the future, and so this might help basically as being an adjunct technique.
With the setup you have for your elderly population with electrical stimulation, you're flexing the knee, increase range of the quadricep, but then you're closing the hip. With a lot of elderly, don't they have problems with hip extension, and would you want to promote further hip flexion through stimulating the quadricep at that angle?
Well, that's a good question. I could basically work if I wanted at the hip extensions if I wanted, but usually when you stand up from the chair, you use much more the quadriceps to stand up than you use probably the hip extensors. And the hip extensors, it's more difficult for you as well to stimulate. You have a larger muscle area there, so it would be more difficult to get changes in these muscles. And so I think that by going to the quadriceps, although it might not be the optimal thing, you probably would have to go both, stimulate both muscle groups, but still you can improve this, and by improving this, they can move the hips more, and so they will improve their functionality anyways. But yeah, it's a good point. The best thing would be if I could basically use both, because then they would use the whole system to stand up and do the daily life activities.
Have you tried stimulating them in a flex knee and extended hip, just to, especially on the dorsal ankle relationship as well?
No, I haven't. No, that's not something that we had done.
And Anquan?
Yeah, my question was asked by Brian. I can ask another question. So you used, but first of all, great presentation. I really enjoyed it. Thank you very much. And I want to ask questions about the motor point. Since you're going across the muscle to find the correct point for motor point stimulations. And I'm wondering if for elderly people, say, they have a degenerated motor units, and does it depend on the number of motor units present in the muscle?
It does. So it's a little bit more difficult when you have to find this with the elderly, as opposed to young subjects, as we've shown here. So you need a higher intensity of the current to be able to penetrate deeper into the muscle. You have to go through the skin, the subcutaneous fat tissue until you reach the motor point. And so yes, it is a little bit more difficult with the elderly than with healthy subjects. But then you basically change the parameters of stimulation. Then you can reach as well whatever is left there or whatever you have. But I cannot do anything about the motor units that were lost. I can only basically try to improve the ones that are still there, that are still working.
How did you do the femoral nerve stimulation? Was it at the groin level, or where did you put the electrode?
Yeah, basically to the groin level, and then basically you go with you go with the ultrasound probe until you find the specific spot. And why did we want to work with the motor point? Because with patients at the intensive care units, it's very difficult for you to go into this area. And sometimes, there might be other liquids, urine and other problems that you may have at this region. So you want to avoid this, and you want to go to a place where it's not very humid. And that's why we think that the motor point is much better than going to the femoral nerve, despite the fact that the femoral nerve might get a little bit better stimulation. But
and so the follow-up this question and the question that Inkwon asked, regardless of the femoral nerve or motor point, you're going to use a very big electrode. And this big electrode is going to stimulate a wide range of area, and it's going to have a big receptive field. Mm-hmm. So I know you are very fussy, or I know you are very actually meticulous to find the motor point, but eventually you're going to use a big electrode regardless. So a few centimeters away from doesn't make any difference.
Well, it makes difference mainly because of the discomfort. And then if I have a smaller electrode, basically I have more discomfort and I have more current density at that specific small area. And then I could use smaller electrodes instead of using large ones, but that would be one more problem on people accepting to be stimulated. So I have to balance about all the different limitations that I have with the neuromuscular electrical stimulation. So going with a larger one, yes, you're correct. I have a larger area. But one of the things that is important, if I go with electrodes, for example, at the femoral nerve, and I have the distal electrode, which is usually placed, just a little above the patella, this current has to, undergo a very large area, and then of course, I'm stimulating probably much more muscles than I want to. As opposed when I go to the motor point, I have a smaller distance here, so it's probably a little bit more effective in terms of concentrating more the current at the place that I want that current to be applied at. So motor point is probably better, but I still would use the large electrodes because of less discomfort. And then I think that at the same time, as I showed there, sometimes you may have more than one motor point for the same muscle. And then basically by using large electrodes, I would get all the motor points that might be, at that specific region.
So, Marco, I missed the point. I know you're going to use the doublet to evaluate sort of the maximum torque. Then you're going to use a short series of trains to produce half of that torque. And you're going to do that at 100 hertz, and it's like, is it 1 second on and 2 seconds off, or what? What was the protocol for the preservation protocol?
Well, the preservation protocol, it starts with longer duration contractions. So the idea is that, you kind of, when you have, let's say, a slow walk, you contract your muscles for a longer period of time, and you have a little bit more rest between the contractions. And so basically with the humans, we're going to use, so you have longer duration contractions, and then you start to decrease the duration of the contractions. And then you're going to go with, kind of a more short period contractions, but alternated, kind of trying to mimic what would be a walk.
Right. So you're going to, but your torque, the target torque is very small, right?
It is very small.
And so my concern is that the Hinneman size principle works the other way when you use direct stimulation. You recruit the biggest ones first. So if your torque target is very small, so your current is going to be very low, you may only recruit a few of the very biggest motor units to produce that torque.
Yeah.
So I'm wondering at the end of the day, is that going to be protective? Because you're not going to be recruiting half of the
No,
muscle.
I'm not going to be recruiting.
A very small fraction.
A very small fraction, yeah, that is correct. That is a limitation of the technique, but I wouldn't be able to go around this technique. Oh, there are possible ways. For example, what they have done with other stimulators, but then I would need to have more channels, and then they have what they call a stimulation that is rotation stimulation. So you rotate the points where you stimulate the muscle, and then you can have a higher evoked torque with less discomfort. So that would be a possibility. Then by doing this rotation, I would get different motor units being activated. So that is what Professor Mafuletti says that is probably one of the best systems that he has seen so far to use with electrostimulation. But the problem then is that, well, I need to have a system that is easy to use, that I can use and enter fast at the intensive care unit. I can go out faster of the intensive care unit. And although it has some of these limitations, and one of them is that, the only way around is probably trying to increase the intensity and trying to get as many motor axons as I can at the motor point, but it's going to be all limited to the ones that are closer to the electrode. There's nothing I can do to overcome that. And I don't want to go, I could go higher with the intensity of the current, and then I could go deeper into the motor point, getting more motor axons. But at the same time, as I mentioned, I'm trying here not to strengthen the muscles of the ICU patients. I'm trying to have some contraction over the day as if it was a short walk for 20 minutes. And this is basically, what some elderly sometimes they do. They don't walk too much, but some contraction at the muscle. I think it's going to be able to decrease the amount of muscle loss that I'll have. But I cannot go, too much with too much time, because one of the problems that we want to avoid is rhabdomyolysis. And then if you have too much muscle damage, and electrostimulation has been shown to produce similar effects as an eccentric contraction, in terms of muscle damage. And so then I increase, the amount of proteins on the blood, and this can actually lead to problems as kidney failure. So it's very difficult because it's kind of a blanket that is small, and you try to cover all the things, but some of them are compromised. But yes, that is a big limitation. But still, I think that by contracting the muscle for 20 minutes, just 20 minutes, might allow you to decrease the amount of muscle loss that you have.
Darren, you still have a question?
Yeah, Marco, in your OA study, you said that after 8 weeks, these people had an increase in their torque. Do you know how much was the increase? And do you know, was that like a linear increase over the 8 weeks? And then also any estimations or expectations of how much further or longer you can keep going, and would they continue to increase, or is this?
Well, let me see if I can go back here. I don't remember off by heart, the exact values, but basically, what we didn't look, we didn't have measurements in between, so we had just before and after the 8 weeks, so I can't tell if it is linear or not, so I wouldn't be able to answer that part of the question. But basically here, well, you can see it's not, a very large amount, but you have about, let's say, maybe 5–10% of increase in the muscle torque that they're producing. And well, I have to think that if I don't do anything, they're going to lose more. Even if they didn't lose anything, was a gain. So that's the first thing that is important for us to understand. So if I was able just to maintain their force over the weeks, that was a gain, because if they don't do anything, they're going to lose. And then if I had an increase, so actually it's not just 5%, so it's the amount that they would lose plus this 5% that they gained. So it's probably something about 15% that they gained over these 8 weeks time. What was the second part?
Do you expect that that's a linear increase? Do you think that it's actually?
It's not linear, because if you look at, well, the protocols for strength training, they are not linear, right? So for example, if you train for some period of time, so usually it takes you about 4 to 8 weeks, to have improvement in the muscle structure and muscle function. But then from 8 weeks to 12 weeks, basically you don't have an increase. So you have to change the protocol, and then you have to come up with a new overload to have, a further increase in your protocol. So it's not linear. I would say that it's more like a stair, and it's just like any other strength training protocol. And I'm saying that because we did, 2 studies with eccentric training for the quads and for, the plantar flexors, and basically that's basically what happened. So you have increase at 4 weeks already in muscle structure and muscle activity, and then in muscle torque. And then you go up a little bit more at 8 weeks, but from 8 to 12 weeks, you don't increase. So no, it's not linear. I wouldn't expect to be linear.
Raph, did you have a question still? Or? Yeah. Okay. Art.
Just to follow up on Jim's question, if you're stimulating the nerve, do you get more physiological recruitment order? And then is there a difference between stimulating the nerve and the motor point in terms of, let's say you produce the same amount of force and you did training, would there be a difference in how much muscle mass you retain or measures?
It's not the same as I showed, or if you look at motor point and femoral nerve, well, it's a little bit better with femoral nerve, but it's not fantastically better than the motor point. So the motor point is still a good place for me to stimulate. Regarding being more physiological, I don't think it's more physiological, because in both situations you are basically taking whatever are the motor axons that are close to the electrode site. So I'm probably getting more motor neurons at the femoral nerve because I have less fat tissue and probably the distance is a little bit smaller, as opposed to the motor point where I have more fat tissue, so I have a larger distance. So that's why I lose a little bit with the motor point as with respect to the femoral nerve. The other point is that, well, we tested this only in young women, and my expectation is that for men it's going to be the opposite. Men probably are going to be much easier at the motor point as opposed to the femoral nerve, because they have much less fat tissue above the motor point. So I don't have a complete answer to your question in terms of it is better or not in all situations, but the experience that we had there was just a little bit better, but it's not something that, oh, I should use the femoral nerve in any situation. No, I think the motor point is viable and it's very good, and it can produce the adaptations as you saw with the elderly. So.
Well, my question is about the use of that method for improvement of performance.
Okay.
In the 1970s, when East Germany still was a country, it was said that the East German athletes were training using electric stimulation. Is there any scientific evidence that that can be used to improve performance?
Yes, there are several studies that have been done, basically that they use electrical stimulation together with, the strength training program. And they have shown basically that, yes, you can improve your performance by using electrical stimulation, although it cannot go to the levels of the Russian claim that you would go up to almost 50% of your 100%. But yes, it helps to improve muscle structure and muscle function, and there are several papers that have shown that.
And what kind of performance is very improved?
Well, then it depends. For example, jumping, there are some volleyball players that have been using, electrostimulation at the quads to improve their jumping performance, and then apparently helps them, basically they do lots of jumps during, this task. And apparently it's good, to improve the performance in jump. But I'm not sure about all the different sports that they have used electrostimulation, so I wouldn't be able to answer exactly what exactly has been done with all the different sports modalities.
Is it used now?
It is used now, yes. There are teams that have been using, and it's used also for rehabilitation.
Brazilian soccer players?
Brazilian volleyball players are using. Soccer players, I'm not completely sure. But for volleyball players, yes, they have been using that. I had a master student that, attended my muscle mechanics class, and then after that he started using electrical stimulation with the volleyball players at, national team level. So, yeah, there are some groups that have been using it.
If I may add to that, there's a sprint coach in PC right now. He uses electrostimulation for his sprinters, and his rationale is that by stimulating, you can stimulate the muscle with more contraction than maximal voluntary contraction. So just exposing the sprinter to this supra-maximal, effort can be hoping to increase his higher capacity. So that's something that's being done in Canada right now.
Well, perhaps one of the things that you might do is by using electrostimulation, you might increase the rate of force development. So that's something that we would have to look at, because this is very important for the athletes. It's how fast you can produce force, and this sometimes is in a sprinting. It's basically the start that's going to give you the advance over, the few seconds that you have in 100-meter run, for example, and so. That's why I think it has some good applications for mainly for the fast sports.
So would you think that the best sprinters use that?
I don't know, but if I was a sprinter and I have some evidence that it helps, I probably would use.
Just in piggybacking off that, is there any research that's shown long term if you use electrical stimulation, since the patterns, it's asynchronous or synchronous versus asynchronous, that it could actually be have negative effects, because the fact is that you're not going to have proper muscle recruitment patterns, or it could disrupt your proper muscle recruitment patterns. And that's what we constantly talk about. It's not always just force development, but how you're recruiting the muscle, say a tennis player or something like that. Could you see negative effects from that as well?
I don't think that we have gone so deep into into the question that you're asking in terms of studies that have looked at that. So the first thing is that we would need to have a asynchronous way of stimulating the muscle with the same parameters that I do it synchronously, and that's something that is not in place yet. So that's there's a methodological problem, there's a technological problem that we don't have stimulators that would allow me to do what you're saying. And one sad thing is that in this lab, we had a professor, Yuanting Zhang, that's when I did my PhD, and he was trying to make electrical stimulation more physiological. And what he was trying to do is he was trying to increase the coefficient of variation, or the coefficient of variation in electrostimulation is 0. It means that you always have a periodic stimulus. So the next stimulus is always at the same time, distance between stimuli. And what he was trying to do, he was trying basically to come up with a program that you would increase the coefficient of variation. Apparently, the coefficient of variation in our voluntary contractions is about 20 to 25%. And he was able, in 1994, he was able to create an electrical stimulator that he was able to go up to 15% in the coefficient of variation of the stimuli. He couldn't go further because the computers that we had at that point in time didn't have, time enough to process all the information and create that pattern of stimulation, because you'd had to create it before and then you would be able to deliver it. And so the processing time was not very good. That was when we here in the lab, we started having the first computers in our desks. Before that, we had just monitors that were connected to the mainframe of the lab. And so it was not very easy to get that, but he was able to do that in 1994. And it's unfortunate that, he didn't get funding. He went back to China. And then I think he didn't follow up on that, but that stimulator that he developed, I think was more, was a little bit more physiological, and would be very nice if you could test something and see if we would have something that was an asynchronous stimulation, and then we could compare. So no, I can't answer your question because you don't have the technology to do what you're saying.
So just contrary to that, like that would be super cool if you could do that. But has there been any study that simply just looked at using synchronous stimulation and see if it did affect motor improvement patterns pre and post? Like just enter a protocol like that?
You do have, as I told, peripheral and central effects. So whenever you stimulate the muscle, you do change things at the brain. And then at the same time, when you have that reflex contraction that I showed from 17% to 45%, there you have the orderly recruitment of motor units. So what is being tested right now as we speak, we have some groups that are looking at what they call the wide pulse, and high frequency stimulation, because apparently that brings, some input from, the brain. And so then you have not just your synchronous activation of the most superficial ones, but then you're bringing other motor units from the central pathways. So that's the way that they're trying, but I don't think that we have had experiments that have, compared enough these two situations that I would be able to answer your question. I think we're still learning on how to use, this wide pulse, and that's why our stimulator, we use at least 1 millisecond duration to 2 millisecond duration in our pulses, so that we try to get the central information as well. But we would need animal studies that would look at the brain, basically to see how much of this stimulation actually brings a little bit of functioning of the brain, and then activate it, in a kind of more voluntary asynchronous way. But I don't think that we have reached that point yet.
And last question.
I don't have any question. I just want to comment on the application of these type of stimuli during voluntary contractions. And regardless of the motor control mechanism that Graham actually indicated, that it may interrupt the actual motor control of the execution of the task, it may increase co-activation in the muscle that reduces muscle force first. And the most important thing is activation of nociceptors that are inhibitory actually afferent feedback. And again, those nociceptors also are going to actually reduce voluntary activation. So I think those people that want to use this should be very careful, because I think contraindication or the negative effect could be even more than the beneficial. I think, but can be tried.
Oh, I think differently. I think that you have more positive than negative effects, but still these are limitations of the technique. And then for some of these patients, you have no other choice. If you could come up with other choices that you could stimulate the muscles and have them lose less muscle mass and muscle force, I would agree with you. But as we do not have at present time any other type of situation, then I still would stick with neuromuscular stimulation.
My comment was about athletes. Sorry.
For athletes.
I mean, about athletes,
okay.
we have to be careful.
All right. No, for athletes, I would agree with you, because with athletes, that is correct. As I showed, it's much better to do voluntary exercise than trying to come up with some artificial thing that might improve some things, but not necessarily in all subjects. And if you're using, as you said, very strong stimulation, then you might have contractions. And if you don't want that, that might not actually be the final result that gets. So that's correct. Yeah, I did understand the question.
All right, let's thank Dr. Vaz one more time. All right, next week's speaker will be Dr. Brent Edwards, who will present on predicting overuse injuries in sport, lessons from mechanical fatigue tests. See you next week, and feel free to help yourself to coffee when you leave the room.